Welcome to this week's edition of Ask an MS Expert. I'm Jon Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. I want to thank you and welcome all of you who are joining us on GoToWebinar, Facebook Live, YouTube Live, and Twitch. The MS Society's Ask an MS Expert webcast is designed to give us a place for the MS community to connect and to connect you with MS experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your comments and questions in the GoToWebinar chat box. MS navigators are online throughout today's program, answering questions and connecting you with the very best resources. Magnetic resonance imaging, or MRI, has made it possible for neurologists to visualize and understand much more about MS and the underlying pathology of the disease. Today, we're continuing our conversation about the updated international MRI recommendations for people living with MS, and once again, we're joined by Dr. Scott Newsome. Dr. Newsome is an associate professor of neurology and the co-director of the Multiple Sclerosis Experimental Therapeutics Program at Johns Hopkins Medicine. Welcome back, Dr. Newsome. Thanks for being with us today.
Thank you. It's great to be back, John.
Before we get into those MRI recommendations, as a member of the group of experts that developed the National MS Society's guidance for people living with MS when making decisions about the safety and timing of COVID-19 vaccines with certain disease-modifying therapies, I'm hoping you can spend a few minutes updating us about what the experts know and what the experts are recommending when it comes to the COVID-19 vaccine for people living with MS. Now that a booster has been recommended for all 3 available COVID-19 vaccines in the United States, who should get that booster and when is someone eligible to get it?
Yeah, no, this is a question that comes up, I think, every day in clinic. And I just want to define what booster means, because I think there's a lot of confusion out there about what's a booster versus an additional dose related to the vaccination. And so, when we think about booster means that you're reintroducing to the immune system the vaccine that it's already seen in a way where the vaccine response has waned over time. So the best example I can give is like the flu shot. When we get the yearly booster flu shots, it's a booster because, from the year prior, the vaccine has waned over time, or at least the protection has waned over time. Additional dose, which we'll get into, I'm sure, a little bit later, is in individuals where maybe the first vaccine or second, as it relates to the mRNA vaccines, is not mounting as good of a vaccine response, maybe because of age, maybe because of a comorbidity, a medication that's not allowing the vaccine response to be as normal as it should. And so additional doses in that context. For booster, though, this is an evolving sort of field. Things seem to change day to day. But when we think about who are those eligible, it's those that are 65 and older, individuals that are 18 and older who may be living in a long-term care facility, those who are 18 and older who have a medical condition that may put them at risk for whatever disease that you're trying to prevent the person from getting with the vaccine. And then individuals who are 18 and older who work maybe in high-risk settings like doctors, nurses, etc. So again, it's very important to figure out the nuances between booster versus the additional doses, but I would encourage patients to talk with their providers about the nuances with these differences, and also to ask them, am I available?
When it comes to getting that booster, do people have to get the same vaccine type that they originally received, or can they mix the dosing of the booster shot?
Yeah, so recently, as I think many of the audience knows, the mixing and matching has been approved with the various vaccines. But I will tell you that we are counseling people, at least for the mRNA vaccines, to try to stick with the same vaccine that you originally got, because there really aren't studies up to this point to tell us, how safe is it? I mean, we assume that it is safe, and we've had some people actually do the mixing and matching and have done fine, but more to come with that. And I will, one other point, sorry. It may not be up to the patient, right? So maybe they're in a region of the world where, say, they got the Pfizer the first time around and they only have access to the Moderna or the J&J. And, I've been a big proponent. It's better to get vaccinated than not vaccinated. So in that context, mix and match if you have to.
It's a good time to revisit this question. Does the National MS Society recommend one vaccine type over another?
So this is sort of an ongoing, I don't want to say debate, but conversation where, going back to what I mentioned, any vaccine that the person can get is the vaccine for the individual, if they're only eligible or able to get one specific type of vaccine. However, there are experts that feel maybe the mRNA may be a little bit better in terms of improving that vaccine response. And that might be more in the context of sort of these additional doses. But more to come with that, because I think, again, we need more studies to help guide us.
I think you've already started to answer this question about that additional dose. Recently, the CDC issued a clarification for people who are immunocompromised, stating they might be eligible for an additional dose and booster. Can you explain what that clarification means?
Yeah, so I just alluded to it, where the additional doses are really geared towards people who may not have as robust as a vaccine response to maybe someone in the general population that doesn't have a medical condition that prevents a good vaccine response. And so the additional dose is really in the context of that. And I think about our MS patients who may be on certain medications that blunt the effect of the vaccine response. And what we're telling them is that there may be an optimal timing to get that additional dose, depending on the medication you're on. But based on what the CDC guidelines tells us is that if you're going to get an additional dose, it should be 20 days or more after the second or third vaccine that someone has had. And this is important with some of the therapies we have, because based on some studies, including a MEET-Bar-OR study showing that with the B-cell depleting therapies, there may be an optimal time after the infusion where the person will have a better response to the vaccine. So, again, more to come with that, but I think it's very important to talk to the healthcare provider of the patient.
Well, thank you for sharing that very timely update. Now let's talk about that MRI exam. And before we wade into some of the specific updated recommendations, can you give us a quick review of what an MRI scan is and why it's important in diagnosing and treating MS?
Absolutely. So you mentioned MRI stands for magnetic resonance imaging, and it's an imaging technique that really is unparalleled for looking at different organs and tissues within the body. And what it is supposed to do is supposed to tease out pathology, problems that are within the body that may not be visualized just with someone standing in front of you. And so what I do like to tell people is that MRIs do not use radiation in order to acquire the images. It's very, very important. They use magnetic fields and radio waves. And so when we're asking people to, get in that little tube, and we're asking them to do that year in and year out, we just need to remind people that this is not radiation. This is not going to put you at risk for developing cancer. As it relates to MS, it is really the most sensitive tool that we have today to help aid in the diagnosis of MS and also to follow our patients over time, especially in those individuals that are put on disease-modifying therapies. And it helps us determine, okay, is this person on the right treatment path or not, based on new lesions that may form? And then also some of our therapies can have consequences. There are safety concerns with some of our treatments, and we want to do MRIs over time to also look at, whether someone is having a safety-related issue from their medication that they're on. So it's sort of a dual role.
Recently, there was an international consensus of MRI recommendations, which provided updated guidance. And when you and I last talked about this updated guidance, we discussed how and when to use MRI for diagnosis and the recommendations for the use of gadolinium contrast in diagnosing and monitoring MS. So let's get into a few more of those international recommendations. Recommendations vary on the timing of an MRI exam based on whether we're talking about a baseline exam for someone who's new to MS, or if someone is starting disease-modifying treatments, or if someone is having breakthrough disease. What's important for us to know about timing MRI exams?
Absolutely. So you mentioned at the diagnosis. So we really, I think most of us will do an MRI to help diagnose a person with MS. And, MS is still a clinical diagnosis that is supported by paraclinical testing, and MRI being the number one test. So we heavily rely on the MRI to, look at mimickers of MS. So at baseline, we like to do an MRI, and this is whether someone starts on a medication or not. And then over time, at least in relapsing onset MS, after someone starts a medication, we usually like to do another, what we would call first on treatment MRI, around 3 to 6 months out from the start of treatment. Now that 3 to 6 months, I know it's sort of a wide range, but this will depend on the treatment that someone is on. And this goes back to the consensus that we had around that particular point of the guidelines. Also, if someone switches from one medication to another because maybe they're having breakthrough activity, we will repeat the MRI about 6 months after that switch, because that will now be their reference new baseline MRI. And then let's say, after someone starts the medication, they're doing well, that 6-month MRI looks good, clinically they're doing well, then we'll repeat the MRI about a year or so out, and typically yearly thereafter for a period of time, really early in the course of the disease. Now, if someone is really rock steady stable, then maybe we'll go to every other year for a period of time. And then there are some people that we end up saying, okay, well, you're in your 60s or 70s and you've been on a medication that may not necessarily cause a brain infection. Maybe we don't need to do an MRI unless something comes up that catches our attention. Now, similarly, gadolinium, I think up front, the consensus is doing gadolinium enhanced imaging to help with the diagnosis of MS, because we know that we can get an earlier diagnosis if someone has an enhancing lesion. And then probably for the first few years at least, doing contrast to really monitor what's going on behind the scenes from an imaging perspective. And then down the road, certainly for some of my patients, we've opted to do non-contrast MRIs. And I'll just touch on one last point. In progressive MS, there's where there's probably a little less consensus. I would say that, doing gadolinium MRIs are not done as often in progressive patients. And that was consensus around the international guidelines.
We heard from Sandy, who shared that she was told not to be overly concerned if she saw slight changes in her MRI because of differences in positioning of the image itself or the strength of the MRI machine. How do the updated recommendations address standardizing some of this? And by the way, when should Sandy be concerned?
Yeah, this was one of the big goals of this international consensus, was to come together to figure out what is the bare minimum protocol and sequences that our patients should have, because of this situation where if someone is on, let's say, a subpar MRI versus the higher Tesla strength, like a 1 Tesla versus 3.0 Tesla, you're going to likely see differences. And so what the recommendations are is, okay, maybe in the past you had MRIs that were not as high quality as what you're getting now. We ask people, well, get into the scanner, the same scanner if possible, with the same Tesla strength. So you're comparing apples to apples and not sort of apples to oranges when you're comparing, maybe a subpar MRI scan. And, I will say for some patients, when that occurs, we'll do the MRI in the better quality MRI scanner, and then we'll say, okay, well, let's repeat the MRI in a few months versus what we usually do is 6 to 12 months. So we have a closer reference scan. But I will say to Sandy and whomever else is listening that MRI nowadays, there are bare minimum recommendations, and this is coming from international experts. And so we have, information, a paper that you can give to the radiologist, or your clinician can give to the radiologist, say this is for the well-being of my patient.
How do doctors monitor treatment safety with an MRI?
Yeah, so, if someone is well controlled on whatever therapy they are, and the therapy happens to have a side effect that can cause, let's say, brain injury, whether it's an infection, a stroke, or other, then we will do an MRI periodically, even in that maybe older patient that's quite stable. So what I'll often do is every other year MRI if someone's on a medication that might cause PML, for example. And then, if someone has new neurological symptoms that are unexpected, we will go ahead and do an MRI in that context. So if there's any change, then we all recommend doing an MRI, and that could include spine imaging as well, depending on what the exam shows.
Special populations and special situations, things like pediatric MS, pregnancy, and the postpartum period, these can require special considerations when it comes to an MRI exam. Do the updated recommendations support MRI for pediatric MS patients?
They do. Actually, these special populations, there was a lot of discussion around this because the prior guidelines amongst the different groups that got together didn't really focus on these special populations. And so, yes, absolutely, pediatric MS. It's essentially like adults. The recommendations are very similar, with one caveat. Since pediatric MS, the treatment availability is less than what we have for adults. The pediatric MS specialist will often do more frequent MRIs upfront and over time to justify why the child has to go from maybe a low potency disease modifying therapy to a higher efficacy disease modifying therapy. Because if you're seeing multiple new lesions accrue in a short period of time, that's a bad sign. And so they can leverage that information to bring to insurance companies to say, hey, this child is in trouble. This is why we need to switch. But other than that, it's really exactly like the adult guidelines.
Are MRIs safe during pregnancy and postpartum?
So MRIs without contrast, absolutely. During pregnancy, if a mother has to get an MRI, and that's usually not related to MS. These are related to non-MS related factors, like someone may have a stroke and an MRI needs to be done. That's typically done without contrast. Contrast can cross the placenta, and that can cause major issues. So it's usually not done. Postpartum, MRIs are obtained in most mothers. Usually the recommendation is 4 to 8 weeks after delivery to have a re-baseline of the person's MS and to help determine, does this person need to go back on their treatment sooner than later, because many mothers want to breastfeed. And even though contrast is typically not favored postpartum, because there is some expression in breast milk, what we will often say to the radiologist and the mom, do this pump and dump technique. So for 24 hours, pump, get the breast milk out after the MRI is done, and just get rid of it. And then you can go back to breastfeeding. So there are creative ways to do the contrast in that postpartum period.
Avery wrote in saying she felt her MS was controlled during her pregnancy, even though she wasn't on her DMT at that time. Now her doctor wants to get a post-pregnancy baseline MRI. Is this something that's recommended?
Absolutely, absolutely. And as I mentioned, that 4 to 8 weeks after delivery is sort of a good time window to reassess. And if it's decided between the mother and the clinician that, okay, let's say that 4 to 8 week MRI looks good and stable and breastfeeding is going to continue, then the usual recommendation is probably another 3 to 6 months down the road after that initial baseline MRI. And the dialogue should continue to go back and forth with the patient and clinician about, okay, when do we feel comfortable restarting a disease-modifying therapy? Because our therapies really are not geared towards using them during breastfeeding or, in fact, during pregnancy.
Well, you've shared some great information with us today about these new international MRI recommendations. What would you say are the top 3 takeaways that you'd like our audience to remember?
So I would empower the patient to ask about their MRI, the quality of their MRI. Are they getting an MS type MRI, a protocol based on the international guidelines? And don't be afraid to ask your clinician, because really, the clinician is there to help you and to help prevent disability. Number 2 is get an MRI. So, there are some people that maybe they started a medication not too long ago, and they haven't had a repeat MRI in like a year or 2 after they started their medication. And I would reach out to your clinician and say, hey, based on these guidelines, it seems like I would be a good candidate to get this MRI. And number 2, I think questioning the clinician about gadolinium. Do I need to continue doing gadolinium with every MRI? Because there are some emergent studies showing that maybe there's some toxicity that can happen long-term with repeated gadolinium, MRIs. And it's okay to ask questions. There's nothing wrong with asking questions. So I empower the people listening to this that please do ask questions. That's the only way we can help you.
Well, I want to thank everyone who submitted their questions today. And thank you, Dr. Newsome, for being with us.
Thank you, John.
Before we close, I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you with the very best information and resources on living with MS. You can reach an MS Navigator by phone, email, or through the Society's website by chat. For information and resources on MS, of course, please visit the Society's website. You'll find research updates and news, information on connection programs like self-help groups and MS Friends, ways for you to get involved, and you'll hear about upcoming events near you. Remember, you can connect with the National MS Society and others affected by MS on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And I hope you'll join me every week on the Real Talk MS podcast, where I continue the conversations that we start here. You'll find the Real Talk MS podcast at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. I'd like to thank Dr. Newsome for joining us today. Please remember that a recording of this webinar is going to be available at the Society's website at nationalmssociety.org/MSexpert, as well as on Facebook and YouTube. I hope you'll join us at this same time for next week's edition of Ask an MS Expert. You can always find our upcoming program topics on the National MS Society's website. And now I have a favor to ask each of you. Getting your feedback on today's webinar is important. So you'll see a survey pop up in a moment when we close out the webinar. And if you're watching on Facebook Live, you'll see a link to that survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us to continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to please fill it out. On behalf of Dr. Scott Newsome and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.